This is STR's first ever Shark Tank launch. This is meant to be an innovative session where we get to evaluate a couple AI companies in thoracic and cardiac imaging. But I don't want to take too much of the time. This is really for them to show their pitch to you guys and what they do and how you could use it in your practice. This year we have two companies, 4DMedical and HeartFlow. They're each going to present a little short presentation, and then I'll ask them a couple questions, and then at the very end we'll hopefully have time to open it up to questions from the audience. So our first presenter is 4DMedical, so please welcome Dr. Joseph Mammarappallil and from Duke University, and Matt Tucker, CCO of 4DMedical.
Thank you, Melissa. Well, good morning, everyone. I'm Matt from 4DMedical. We believe lung imaging deserves more than morphology. CT is great at showing us structural information, but today I'm going to describe a new FDA-cleared technology called CTVQ, which shows how lungs work with both ventilation and perfusion from a single non-contrast CT scan. So there's no extra scanner time, there's no new modality hassles, just functional intelligence built for your current workflow. So pulmonary disease is functional with both airflow and blood, but our everyday toolset is structural, whilst our functional tests are limited. Nuclear medicine VQ is a really powerful tool, but it's not always available and often sits outside routine clinical workflows. PFTs tell us how much, but not where, and hyperpolarized MRI is not scalable. So that leaves radiologists often inferring function without actually seeing it. We believe we can do better. In CTAF and embolic disease, perfusion patterns matter. In COPD, ventilation heterogeneity matters. Surgeons need functional reserve maps to de-risk resection or volume reduction therapies. In ILD, regional functional change can precede the visible remodeling. These are daily problems that CTVQ may bring into focus without adding a new exam. The beauty of CTVQ is it's just a drop-in software layer. You can feed it a CT used in routine clinical workup, so a standard non-contrast HRCT, and it outputs quantitative VQ maps, mismatch heat maps, and a structured functional report that attaches to your study in PACS, whilst all the quantitative metrics that the treating doctors need are automatically filled in for you via DICOM structured reporting. So where's the magic? CT derives both ventilation and perfusion from the same inspiratory and expiratory CT scan. For ventilation, we're tracking the lung motion using piecewise spatial correlation. Then we compute regional expansion using Jacobian, and this gives us the ventilation map, where we show cool colors as better airflow and warm colors showing impairment. For perfusion, we use that same ventilation field to correct the CT density values. We remove the large vessels and interpret the remaining regional density differences as blood flow. The outcome is a fully contrast-free ventilation and perfusion map that is tightly co-registered to the CT and reported together from a standard CT scan. So we're doing a few things your clinicians really want. They want robust lobar segmentation and volumes. They want physiological modeling to derive both ventilation and perfusion, and then they want a quantitative aggregate that by lobe. And this results in a trustworthy, interpretable, functional map alongside the CT you already read. And we built this with radiologist adoption in mind. There's no protocol upheaval, there's no extra slots, and the outputs arrive where you already work, in the PACS. So we can pre-populate your reporting templates with segmental functional metrics so your turnaround time stays really tight, and the patient only needs to attend for one study. So let me walk you through why CTVQ is so easy to adopt. First, it's a non-contrast solution, so there's no contrast injection, no radioisotopes, no preparation steps. So that alone removes significant barriers, especially for renally impaired patients or anyone who can't tolerate contrast or isotope studies. And then secondly, it's the clarity. You get color-coded functional maps that are paired to a quantitative structured report. That means as radiologists, you're no longer guessing. You have the objective numbers and a visual overlay that easily are quick to interpret. Third, and this is probably the biggest advantage, is the accessibility. CTVQ runs on the scanners you already have. There's no new hardware. There's no need to do a scanner upgrade and no workflow disruption. If you can acquire a chest CT today, you can run CTVQ tomorrow, probably in the same afternoon. And fourth, it's patient-friendly and cost-conscious. Because we can leverage that routine CT scan, there's no extra visit, no radiopharmacy scheduling, no consumable costs. Patients appreciate that simplicity. Your hospitals will appreciate the efficiency. From a value standpoint, CTVQ is a software as a service model, so there's no capital expense outlay. It aligns costs with study volume, so you don't need to invest in new equipment or dedicated imaging hardware. And we're also CPT eligible, so this isn't just a cost center, it's actually a billable service. And importantly, it frees up that nuclear medicine capacity. So any VQ scan you replace with CTVQ opens up a slot for the higher value nuclear procedures, particularly SPECT and theranostic studies, which are often bottlenecked today. This is the first test that taking a study from nuclear medicine, they will come and thank you for. And last, CTVQ offers accessibility at scale. Because CT is one of the most ubiquitous imaging modalities in the US, CTVQ can be deployed anywhere. A community hospital, an outpatient imaging center, academic medical centers, everyone can participate. Now here's the clinical unlock. Everywhere that clinicians rely on nuclear VQ today, CTVQ gives them the same functional information, but immediately off the CT they already ordered. So there's no waiting for that nuclear slot. And yes, nuclear VQ scans are performed readily in the US today. There's over 1 million performed, and very few of those are for acute PEs. For procedural planning like LVRS or bronchoscopic reduction, CTVQ delivers that lobar and ventilation perfusion right in the moment of decision making off the CT that they're already using for workup. For embolic disease, we show perfusion defects on the same scan used to evaluate or monitor for the PE. And for chronic conditions like CTEPH or transplant rejection, CTVQ tracks the regional function over time without adding another modality. So it's from one scan, you're getting one visit, and you're getting faster answers. That's the clinical power of CTVQ. And it's not just a clinical fidelity, there's operational efficiencies here. By keeping that functional assessment inside CT, we avoid the downstream imaging and reduce repeat visits for surgical planning. Even conservative assumptions justify the software expense. So let's break that down. CTVQ not only improves the workflow, it actually improves the revenue for the facility. Nuclear VQ ties up high-value nuclear medicine capacity, but reimburses relatively low. So replacing a VQ study with CTVQ frees up that slot for SPECT or theranostics, which reimburse significantly more. So here's an example of that down the bottom right. If nuclear medicine forego the VQ reimbursement at $555 and replace that nuclear VQ with CTVQ and a CT, you're generating $757 in reimbursable services. But backfilling that freed up nuclear slot with a cardiac SPECT adds $1,300. So the net upside per case is $1,525. So each time you're doing a CTVQ instead of your nuclear VQ, your system gains roughly $1,500 whilst improving the workflow and patient experience. And of course, these benefits need to be backed by evidence. So for our FDA submission, we evaluated CTVQ in 3 ways to show equivalence and in key areas superiority to SPECT-VQ and dual energy CT. We confirmed quantitative equivalence to CTVQ, lobar and ventilation perfusion measurements that were strongly correlated with SPECT-VQ. We did a reader assessment with radiologists and nuclear medicine physicians where they rated CTVQ and SPECT-VQ side by side, and we showed high agreement in regional functional scoring. And then finally, we did a case-based review where experts confirmed CTVQ identified the same perfusion and ventilation defects, often with better localization due to the correlation to that underlying CT anatomy. Compared with dual energy CT, we go further. Dual energy CT provides perfusion only, CT provides both ventilation and perfusion, enabling that true VQ mismatch analysis in one scan. So the bottom line is CTVQ matched SPECT and VQ and actually correlated better to DLCO. So as a result, CTVQ delivers physiological advantages neither SPECT nor dual energy can offer. So now I'm going to hand over to Joe Mammarappallil to show some clinical cases. Thank you, Joe. My fellow shark.
Hey everybody, I'm a chest radiologist at Duke, and I've gotten to use this technology in some chronic pulmonary diseases, and we'll kind of show you 2 hallmark cases that I think will nicely show you the impact of this technology. So we're first going to look at this first case, which is a patient with cystic fibrosis, and all of us in here, most of us in here are chest radiologists, and if we look at this scan, structurally we can see the abnormalities, you can see areas of bronchial wall thickening, but also within the lower lobes, we see areas of bronchiectasis. So a classic CF patient. When you look at the overall attenuation of the lung, we get that appearance that it does have this kind of mosaic attenuation appearance. And so now I'm going to take you next level with this technology. When we add ventilation images to this, what do we see? Essentially homogeneous ventilation throughout the lungs, indicated by the fact that most of the lungs are green. There's some areas of peripheral defects within both of the upper lobes, as you can see. It gets very interesting when we add the perfusional imaging to that. And when we see the perfusional imaging, it's very dramatically different than the ventilation image. And as you can see within the medial aspects of the lung, essentially preserved or normal perfusion within the medial aspects of the lungs. And if you look in the periphery of the lungs, we can see marked areas of perfusional defects. In particular, you see an asymmetry between the left lung and the right lung. Now, when I show these images to my pulmonologists, they get really excited because if this is a baseline scan, now they have a perfusion image where they can guide treatment and see if this patient is responding to treatment. So this is one really striking case for me that showed me the value of this technology. We're going to move on to our second case, which is a CTEV case. And if you look at this, what's the first real striking feature I see? I see some paraseptal emphysema, in particular within the apices. If I look at this, the overall attenuation of the lung appears to be relatively normal in this patient with known chronic thromboembolic disease. Now let's take a look at the ventilation image first. And if we look at the ventilation image, pretty normal. We can see pretty much homogeneous ventilation throughout the lungs, indicated by green, some areas of peripheral red, defect of ventilation there in the lung bases. But when you now go to the perfusional image, I think you really nicely appreciate how abnormal these lungs are. And we see within both lung apices, again, in this patient with chronic thromboembolic disease, we have marked perfusional abnormalities, in particular right greater than left. And when I show this to our Duke right heart people, they get very excited about this technology because now they have a metric that they can now put these patients on these $200,000 drugs, and they have a baseline perfusional image that they can now jump forward and be able to evaluate, is this patient actually responding to medication? So I would tell you, these are 2 hallmark cases. We've run it on multiple other cases as well, but these are 2 really impactful cases for me that I wanted to show you all. Thank you all.
Thank Thank you so much for that presentation. I'd love to ask you guys a couple questions, if that's okay. First, for the radiologist that is not used to interpreting a VQ scan, how would you have them incorporate CTVQ into their reports?
Yeah, maybe I'll start us off, and Joe, if you want to add anything. But you know, our chief medical officer is a practicing radiologist, so we're really conscious of how that integrates into your workflows. He will definitely lean in and help guide you, but essentially those metrics come straight across as quantitative data. So think of that almost like old BMD studies. You can comment on those if you want, or you can just let the numbers do the talking, and then you add a summary in as the physiology, as the ventilation and perfusion. Now, if that's done concurrently with the scan at the time, obviously that's part of a report, but because we're non-contrast, we can run that retrospectively, so you can go and add it in as an addendum report as well.
Okay. Great. I think a question that a lot of people think about when we talk about VQ scans is thromboembolic disease. Obviously, when a CTVQ scan is not showing us clot, and we think of a CTA PE study as kind of the gold standard of evaluating for PE. So why add this in when we could do a PE study?
Well, I mean, I think all of us know that our ED department loves PE studies, and so that's never going to go away. Obviously, an anatomical clot is never going to be, we're always going to see that with a CTPE study. I think the value of this technology, when I think about it, is this patient that shows up to the ED with shortness of breath, and we can't actually figure out what this patient may have. So all of a sudden you get them a non-contrast inspiratory and expiratory scan, and maybe you see these marked perfusional defects, and maybe now you're like, okay, there's something really going on here. Or more importantly, if you get something that's totally normal, we don't need to move on to that next step, but maybe we need to move on to a PE study if that perfusional image is markedly abnormal.
Mm-hmm. Have you found it useful in patients with contrast allergies also?
Well, you want to take that, Matt?
Yeah, I think that's a primary use model. Is so effectively anyway you would normally use nuclear VQ, so those renally impaired patients. The other really interesting part the company's got is patients where the D-dimer is just ineffective. You know, so pregnancy or oncology patients, we really see there's an opportunity there that having a non-contrast CT used really as a imaging D-dimer, if you like, prior to going on to doing a contrast study where you're looking at the burden of clot, could be a really essential part going forward with CTVQ.
Okay.
We're FDA cleared to do PE. We're certainly not pushing it for the acute PE patient at this stage. We see there's a lot that we can do in that CTEF and chronic thromboembolic disease part.
Okay, that's extremely helpful. Okay, I think we're getting close on time. I want you all to have time to get to the next session. Let's give our presenters a round of applause. Thank you so much for sharing your work with us.